Today, I'm delighted to welcome Dr. Michael Glogauer, who's the Chief of Dentistry at the University Health Network in Toronto. He's also the Chief of Dentistry at the Princess Margaret Cancer Hospital in Toronto. Michael, what role is your hospitals playing in the current COVID-19 crisis?
Firstly, John, I'd like to thank you for, again, inviting me, the opportunity to talk with you and share with you and Canadian dentists about what we're doing here in Toronto in our hospitals. So at our hospitals, we primarily see cancer patients at the Princess Margaret Cancer Centre, and we're also involved in the care of the patients at UHN in general. And we're all aware of the sort of the rules and the elimination of elective care, which is being brought down by the dental regulatory agencies, and in our case, the Royal College of Dental Surgeons of Ontario. And so when that specific edict came down from the RCDSO, I immediately contacted them and let them know that some of the care that would fall under elective care in the general sense really was not elective in for example, our cancer care population. For example, we need to be able to clear patients before they had radiation therapy, for example, and that required sometimes care that in a normal patient would be viewed as elective. And as a result, I was able to secure from them a confirmation that we would be allowed to continue care that in our professional opinion was required in these patients before they proceeded down their cancer care. Yes. So that means that we're doing care here in our setting sometimes that would be viewed as elective out in general care. So so the broad answer to your question is that we are seeing patients within the hospital setting, for example, patients who are on the acute cardiac care wards or the intensive care units who have dental emergencies or dental care that need to be taken care of, for example, in their beds. And we're also seeing cancer patients, both pre-cancer, but we're also getting calls from patients who are either post-cancer, during cancer therapy or post-cancer therapy, who have emergencies or dental problems where they're unable to secure care out in the public. And so for those patients, again, we're seeing them here in the clinic as well.
I think you have an interesting twist there in that you're seeing patients in their beds. It's not just in the classical dental operatory.
Correct. Yeah.
Now, I guess the burning question before we even get into the flow, the patient flow, is: are you restricted in the types of care that you're providing these days compared to pre-COVID-19 crisis?
So that's a good question. So, I mean, we're really having to add another layer onto our professional assessments, whereby there are certain treatments that, we're certainly using the guidelines where we don't want to do we're obviously not doing elective care in cancer patients that truly is elective. But for example, if you've got patients who require or having pain associated with an error, that where restoration is absolutely required, for example, prior to entering in radiation therapy or as such, that care would be done. Whereas perhaps out in the public, you may decide to use an antibiotic, for instance.
Rightio.
Once patients have radiation, we're not going to be able to, for example, safely go in and extract a tooth. We need to sort of be able to deal with these things in advance.
Right. So aerosol generating procedures are being done, but it's particular circumstances here.
Right.
Now, are any of your hospitals on the list of designated centers that the RCDSO has published for emergency care, or is that not necessary?
Right, so we haven't gone that route, even though we have all the required equipment, which we can discuss in a few minutes, mainly because we really, for a couple of reasons. One, we're not an emergency center whereby we take patients from outside. We really have a specific responsibility of looking at the patients who are patients or previous patients of this particular center.
Right.
That's what we focus on.
Yeah. So if I'm a GP, like in downtown Toronto, I'm unlikely to be sending patients your way that I telephone triage. That's what you're telling me?
Right. And so let me be blunt. You could refer patients here, but we would deny seeing. We probably would not see them. One of the challenges that I have is that we get referred patients who are current cancer patients who have maybe not come through this clinic, but are UHN patients. And those patients, when they have a dental emergency or dental issues, I still feel an obligation to see them because they're under the auspices of UHN, but they've never actually been a patient.
Right. So that's interesting. Let's take that type of patient as the type of patient that we'll walk through the process with. One of those cancer patients has a dental emergency or an urgency. What's likely to be, and they're outpatients now, what's likely to be their first type of interface with your department?
Right. So their first, we will get either a fax referral or a telephone referral from usually, either it's going to be coming from their oncologist or it's coming from their dentist.
Right.
And our first step is to essentially triage them by phone, get a true sense of the nature of the emergency, based on their medical history and the nature of their dental problem. We'll make an assessment about whether, when, and if they need to be seen by us.
Right.
So assuming that they need to be seen based on our professional opinion, based on their current stage in cancer therapy, what they're undergoing, and their dental problem, they will then enter into the hospital. And while things are changing day to day, in the past, to get into the hospital, they will go through an interview at the front door. We all have to every single day we come in. And an assessment will be made as to what is their risk of actually having COVID. Do they have any symptoms? If they do have symptoms, they would be sent up to an ambulatory screening clinic and they will be tested for COVID. And usually the answer would get back to us within 24 hours.
Right.
And then we know what we're dealing with. Assuming they have no symptoms, then they would make their way up to our clinic. Again, they would be screened by us as to the nature of the emergency, ensuring that it's something that needs to be dealt with in the immediate term. And then they would enter into, once they pass all those checks, they would then enter into an examination room where we would assess them, determine the nature of the issue. All initial radiography, again, is extraoral to start with. The counter-X machine to do everything we can to minimize any aerosols associated with that procedure. And we would then determine exactly what needs to be done.
Right. And in your clinics, I guess there's multiple operatories or a number of operatories where you're going to do the initial assessment. Is that open plan or is it closed room, or what's the setup? And is it any different from usual?
Right. So great point. So we're fortunate, especially today, that all of our operatories, of which we have 7 of them, are completely contained with a door. And obviously, as we move forward, I think that's going to become the new standard of care. That's my guess. But so we're able to close the doors. Now, again, if any aerosol generating procedures are required, we have one of our operatories set up with an industrial HEPA filter machine, so that the air is completely turned over quite frequently. And the room is that filter is turned on in advance during the procedure, and then the room is left for an hour after to make sure that everything's cleared.
Right. And high volume suction, is there any difference in the apparatus that you're using today?
Right. Other than that HEPA filter not being allowed to leave the room until the procedure is completed. And then again, the PPE that we're using, which are obviously gowns, head caps, N95 masks that are fitted. Everything else is, we try to minimize aerosol generating, but usually for some of our surgical procedures that's required. Everything else, for the most part, is the same.
Right. And N95 masks, you've no shortage of those? Are you able to get your hands on them?
So we're fortunate. We're pretty well being able to. We were replenished. They come by and regularly check our stocks, and we're making sure that we have everything that we need. So we haven't been really limited by PPE. The hospital has been quite generous with us.
Right. Do you add anything to the water, in, the high speed or the 3-in-1 that might change the nature of the aerosol?
I mean, these are great questions. And so, I think, as a scientist, one of the things that, I'm anxious about is that I like the things that we do to be evidence-based. And almost none of the things that we're doing now are evidence-based. There's studies that suggest N95 is overkill, that you don't actually need it. There's some studies coming out. How important is it to have a HEPA filter? Does does there need to be sort of the intake of air? How close does it need to be to the patient? So there are a lot of things that, and I think that's going to be the challenge of the dental regulatory agencies is where are you going to set the bar in terms of when we come back? And I'm very anxious about that because I understand that everybody wants to be protected, but I'm quite concerned that we don't make the bar so high that it's going to be very difficult for people to actually care moving forward. Because
we are all concerned about quality care, accessible care, and science-based decisions. In everything that we do, not only the treatments, but how we set up to do those treatments. Do you think that it'll take us a long time to get the evidence that would be required that would say you would be comfortable making a recommendation about PPE or filtration?
Well, so there are a lot of the impressive thing throughout this entire sort of ordeal is the speed at which science is getting done now. It's quite remarkable. So, we're putting through some studies through the Research Ethics Board, and I can tell you sometimes it takes 3 to 4 months to get something through, and we were able to get something through in 3 days.
Yeah. Well, you do have a unique perspective.
Yeah, with the same level of stringency, it's just if you've got COVID in front of it, obviously people are moving much faster. And I think that really trickles down to the fact that things are getting done incredibly fast. I can tell you in the last probably 3 weeks, I've been sent 7 COVID dentistry related papers from journals around the world. And some of the work is astounding, excellent reviews. There's a lot of work that's been going on. And so, I think, one of the advantages of the global world we live in is that there are a lot of people who are thinking about dentistry in what we're facing. And there's some incredible insights. There's a lot of literature that's being developed. So I'm quite encouraged by that. I think that there's a lot of information out there, and it's just a matter of us synthesizing it all and really making evidence-based decisions on how to move forward.
It's at a time like this when a particular type of professional that you and I often talk about, the clinician scientist, is absolutely essential to help us make the right decisions going forward.
I think that's an excellent point because I think, clinicians are going to have their viewpoint. Scientists are going to have their viewpoint. And I think it really is the clinician scientists who are going to be able to have both. I mean, I can tell, in my, both here, we've had to change the way we do things, but in my private practice as well, I've had to make some significant decisions and have made some significant investments in changing my clinical environment, both for the protection of my patients, myself, and my staff, so that I've really tried to anticipate what the most stringent rules that the DRAs would have to come up with, and have tried to institute those into my private practice, such as sourcing N95 and N100 respirators from China, for example, which surprisingly actually showed up. Getting seals on all my operatories, buying air purifiers for every single operatory. Really, changing the setups of what's in the operatory, taking out everything that we view as unnecessary. So, in a very short period of time, really changed significant elements within the practice setting, which I believe are maybe necessary in the future.
So, are we at a period where there may be a paradigm shift in how we think about a lot of the things that we do in dentistry.
I think things are going to change for sure. I think my biggest concern is that we go too far in terms of restricting how and what gets done. I mean, I understand why the DRAs shut down elective care. The issue is that, we're going to learn what elective actually means, right? No hygiene. I mean, maybe that's elective procedure, but is that truly elective for everybody? What about uncontrolled diabetics? What about people who have significant periodontal disease and have cardiovascular issues?
Right.
In my lab, we study the effects of periodontal disease on systemic health, and we have some exciting results coming out showing that it's not insignificant. And so, I want to make sure that we really start to truly understand what elective is. Now, we could never have envisioned an experiment where we shut down all dental care for whether it's 3 months, 6 months, a year, a year and a half, God forbid. But if we're going to truly be in a position as scientists to truly understand what no professional dental care means to a person or to a population. And I think we'll be having the opportunity to truly understand what actually is elective care. And I believe will probably be depending on the patient group you're looking at.
I think an upshot of what I take from you is that we must be hasty in getting new knowledge. But with all our haste, we mustn't throw reflection out the window. There's a lot of different factors to be weighed in as we inch our way or rush towards whatever the new normal is going to be.
Right. Yeah. And I think, I understand, again, we're all quite concerned and there's a lot of fear out there because there are all these unknowns. But I think, we have to be careful because, yes, this virus may actually be more sort of lethal than the influenza, for example. But I want to be clear, we actually don't know that.
Yes.
People are modeling it like it's absolutely true. But
Right.
until you truly understand what the incidence or the number of people who actually have been infected, which you can't do until you get an antibody test, a serum test, until you actually know we know what the lethality, we know the numerator on how many people are dying, but we don't actually know the number of people being infected. And I think this comes down to the availability of the test, the amount of testing. And so until you actually know that number, you don't know how lethal it is. And so to a certain extent, I think it's irresponsible for people to say, this is more or less lethal than the flu. We don't know. And I think it's important that as scientists, we're sort of upfront and honest with the public that when we say something, that we actually know the answers. And we should let this public know what we don't know. And I think it's important that we let our politicians know, the leaders who are making the decisions, when we say something, is it actually known for sure? And I think that's, as scientists, I think we have to be as responsible as possible.
Yeah. No, well, your perspective is fascinating to me because you're running hospital dental departments. You're primarily gearing up for the new normal in your private practice, and of course, you're a researcher and a scientist, and you're going hell's bells in this area, finding new information in this area right now. So, 25H you're working, Michael. Eh?
Right, I'm trying.
I had a conversation yesterday with a dentist who's also got a PhD in microbiology. And if I was to take away the 3 big things that this person told me, let me float them by you. Said one of the big issues is the unknowns. There's just so many unknowns right now, and we got to know more where we have lots of those unknowns as best we can. The big issue for him is managing the aerosol problem, and he thought that the solutions might be more local than in the ceilings and in the walls, but it's closer to the point of care. This was his particular perspective. And then the last thing that he said to me that I really retained was that there's probably a need going forward for some type of infrastructure that's somewhere between the private dental practice and the hospital emergency room. It's another infrastructure that can take care of this. Let's call it medically necessary care or non-elective care, whatever you want to define it as. And could that be a sustainable hospital dentistry infrastructure across this country? Is that something that could be one of the things going forward?
Right. So, that's a really good question. I think, this is not the first time we've been sort of presented with an extremely concerning virus. Right? And, I think with globalization, this is not like, oh, this is the first time this has happened since the Spanish flu. We've had MERS, we've had H1N1, we've had SARS. I think this is just one of the outcomes, or this is what happens with globalization. And so, I think that we're going to have to really take a step back and think, so what actually, how do we prepare dentistry? And my answer to that right now is, without sort of giving it, maybe I'll change my mind in the future as we get more knowledge, but I think dental practices can be modified. And I don't think that they would need to be modified as much as some people think to deal with this. I mean, we've always practiced sort of standard generalized infection control protocols. This is not true. And I think when this all comes out, this virus is not going to be that much different than some of the other viruses that we've had to deal with.
Yes.
And, I hope I'm right. I believe I'm right. But I think that we're going to see that this can be managed. Maybe we need to change our infection protocols slightly. Maybe we need to make sure all operatories are sealed, but maybe that should have happened a long time ago. Maybe we need to have air purifiers, heavy duty, in our operatories, but maybe that should have happened a long time ago for all sorts of reasons. And so I think this is an opportunity for us to rethink. I just want to make sure that it's done in a sort of an evidence-based, level-headed manner, and no sort of knee-jerk reactions. And the most important thing is, I think that we need to open, when we're allowed to reopen, I think dentistry should be one of the first industries, if you will, that is allowed back in. Because I think, I'd like to believe, and the science validates, we're a lot more than just elective care. And I'm a little concerned that we're at the point now where everything can be treated with antibiotic, because, and maybe not that everything, I'm not saying everybody believes everything can be treated with antibiotic, but I can tell you my practice, patients are coming in 3 or 4 doses of antibiotics, problems not clearing up. One more, and we've seen patients get into real C. difficile. We've seen patients develop a resistant bacteria. And I just want to make sure that we don't get back to the point. We've been trying to encourage dentists not to rely heavily on antibiotics when necessary. And I just want to make sure we don't take too many steps backwards.
Yeah. Choose your poison, eh? Because antibiotic resistance is one of the greatest public health problems facing us today. And we mustn't forget that.
Right.
Well, Michael Glogauer, it's always a joy to talk with you, and you have just so many perspectives, and you're able to articulate them so well. Thanks for taking time to talk to me today.
Right. Always a pleasure. Thanks, John.